Hello and a very warm welcome to all to today's ISNTD Connect. It's my pleasure to welcome you on behalf of the International Society for Neglected Tropical Diseases for this special session in collaboration with the Global Schistosomiasis Alliance, where we will be taking a closer look at solutions to interrupt the transmission of schistosomiasis, but also cell-transmitted helminths. And for this, we're delighted today to welcome our speakers, Milkias Lakew and Endriyas Shobew. Nice to meet you, and thank you for joining us today.
Nice to meet you too.
Hello. Nice to see you here. You're working with the World Vision Ethiopia, and you're connecting live from Addis Ababa. And today you will be shining the spotlight on the progress and the many achievements of a really exciting program, the Geshiyaro Project in Ethiopia, bringing together water, sanitation and hygiene or WASH interventions with mass treatment programs to tackle these neglected tropical diseases, particularly in the Wolaita zone of Ethiopia. So to all our attendees, thank you for being here too. Please do join me in welcoming very warmly our speakers who over the next 90 minutes will share an overview of this very exciting Geshiyaro program led by a coalition of organizations, and will particularly focus on the WASH and also the behavior change communications aspect of the programs. So we are really looking forward to your presentation. It's a 5-year program. There's been a lot of change and progress over the years. So thank you so much for joining us for this update. And without any further delay, it will be my pleasure to hand over the floor to you. And perhaps later on, also taking questions from the audience and hearing a little bit more about your experience with this initiative and how it could be scaled in other parts of the world or even maybe across other diseases. So thank you for your time, and over to you.
Thank you very much, Mariana, and also the rest participants. Thank you for the warm introduction also. So my name is Milkias. I'll be starting to present the Geshiyaro overall project, and Endriyas, the project director, is also with me, so we'll be sharing together the whole project. So to start with, I think most of you are not familiarized with the term Geshiyaro or the name of Geshiyaro because it's not an English word. It is a very local word which we use it in the project operation area, Wolaita. So the meaning is something that cleans inside and also outside. That's the direct meaning from the localities, and we chose it because it's more appropriate to represent the overall project, because WASH is going to clean the environment while the NTD or preventive chemotherapies is going to clean the human body. So we chose to be, picking this word and name the project after this tremendous work. So in the screen you are seeing Sir Chris Horn. He's the founder and also the CEO for Children's Investment Fund Foundation. So I think it's better to start with the donor, because it's good to let you know that where the money is coming from and also the organization. So this picture was taken from the inauguration party in 2018 and also in the first visit of Sir Chris Horn in Ethiopia and also in the project area. So we'll go to the next slides. So these are our project outlines. First, we'll be seeing about the project concept, what's the very concept of the project, and then we'll see also the goal. What are we going to achieve with implementing this project over the 5 years course of period of time? And the next one there are different outcomes in this project, so we'll be seeing also each outcomes one by one. The last part is going to be the social behavioral change monitoring and evaluation aspect of the project. Just to mention here, the E is on the red because evaluation is not mandated to World Vision, because the project is combined with, it's a consortium project. There are implementers. One of the implementers is World Vision, especially for the WASH part. And then the other implementer is going to be Federal Ministry of Health, which is overseeing the mass treatment or mass drug administration activity alongside the ODF or open defecation free activity. So World Vision is mainly responsible for the WASH part, especially, and also the SBCC part. When we mean WASH, the infrastructure is also included included here besides the software components. So we'll see the monitoring parts. So evaluation part is going to be carried out by Ethiopian Public Health Institute and also London Center for Neglected Tropical and Disease and Hygiene. Next slide. These are the project assumptions where the project was incepted in the first time, because as you know, the scientific name of the project is Soil Transmitted Helminthiasis and Schistosomiasis Transmission Break Project, or reducing the prevalence below 2% so that transmission will be interrupted and intermittent. So the first one is to attain the universal coverage for mass drug administration, which is in regards to praziquantel and also albendazole. And the next one is attaining intensive SPF is social behavioral change communication, so that everyone in the operation areas will have a direct knowledge of the transmission routes for these two diseases, and also how to prevent themselves from contracting these two diseases. So we are working rigorously on bringing the knowledge in higher level. The next one is access to clean water, which is around 85% and above. We'll see it on the coming slides. And the last one is creating access for improved sanitation, which is washable latrines. So combining all these activities, then the theory suggests that the transmission break is going to be realized. So that are what we are implementing now, and we'll see the effects on the coming slides. So this is the project goal. As you see, it's bringing about the transmission break in the particular countryside of Ethiopia, which is Walaita zone. It's located on the southern part of Ethiopia. This is to show you the location and the maps of the operation area. So the project outcomes, the first one is mass drug administration, which we are going to see right now. And the World Vision role is providing support for the Federal Minister of Health, because Federal Minister of Health is responsible to oversee the overall mass drug administration programs, but technical supports and logistic is going to be provided or supported by World Vision and other stakeholders. The second one is access to clean water, which is solely implemented by World Vision. And the third one is going to be improved sanitation. And the last one will be improved key WASH behaviors, or the social behavioral change part. So to begin with, as I said earlier, World Vision role is to provide support. So during now the project is being found on the years in the fifth year. So we have implemented 4 years. So across those four years, World Vision was solely supplying the project with albendazole drugs. So nearly each year we are donating 9 million of albendazole drugs for the preventive chemotherapy activities, or for the MD part. So far we have managed to import and donate the Federal Ministry of Health with a number of 35,349,194. So it's a massive number. Also, in this part, World Vision is acquiring, or again, taking the grant from the Vitamin Angels. It's located in the United States, so they are our donors for the past 4 years. So also we want to thank them in this presentation. And the next one is we are also, it's a community-wide intervention, so we are also treating under-2s for HTH. So we are treating them with the albendazole syrup one. So we have so far purchased 100,000 of the syrups, and also we have treated a number of under-2 children. The next one is praziquantel. Praziquantel is morely supplied by Merck, and it's purchased by World Vision, but the grant is from Children's Investment Fund Foundation. So far we have imported more than 9 million of praziquantel for schistosomiasis deworming program. And also we need to thank also Merck, because Merck are the one providing this drug, and also they have given us additional quota beyond our purchasing quantity. So we are grateful for also Merck's. So the one on you see on the right column and with the green font is those are on under importation processes, because we are implementing in our Year 5 project, and Year 5 is going to be finalized on June. But so far, we have started working to import this number of drugs, and soon they will be finalized. So just to indicate you what currently is going on. The next one is the MD in Geshiyaro Project is being, carried out, coupling with digital. We have digitalized the program so that fingerprint scanners, QR codes, and all mobile smartphones are included, because anyone who's taking the drugs is going to be registered. His or her fingerprint is going to be scanned, so that so that we identify those persons in the coming sequences or in the coming follow-ups for albendazoles. So we have imported a number of QR codes, plastic scanners, fingerprint scanners, and IDs. The next one is pharmaceutical equipment, which are PCR and also cattle-cats for testing and detecting the parasites in the operation areas or in the sentinel areas. Also, we have provided a number of pharmaceutical equipments. The next one is producing IC materials, because the MD campaign is going to be carried out in a form of mass mobilization. So in order for us to mobilize the community, we need these IC materials, because it has been helpful in the previous implementation period. So we have designed these kinds of IC materials to teach and communicate our beneficiaries or our target populations. And the last one is providing on-job supportive supervision for FMH. This is on the time of the campaign, and also before the campaign on the time of training the health extension workers or those who are going to actually administer the drugs. We are also, jointly nurturing them and also supporting and training them with Federal Ministry of Health. So this is what it looks like, and then we'll come to the results at the end. So the results are like this. The coverage for albendazole is 75% and above. The last year, at the stage of 4th year, it has been 92%. So it's a great achievement. Our target is to accomplish above 90%. So we have succeeded this as of year 3, because subsequently we have managed to record more than 90% for albendazole treatment. And also the same thing applies for praziquantel coverage treatment, because as of year 3, as you see, 93% has been recorded or registered for the past consecutive 3 years. So this is a great achievement comparing to the target of the project. Okay, the next part is going to be access to water. So Endriyas will be addressing contents in here.
Hello, everyone. Thank you very much for attending, and we are very happy as a project. We are very happy to be part of this experience sharing. Since you are on the 5th year, it's now a time for us to show what we have been doing in the past 4 years. So as Milkias said, before I jump to the access to safe water, as the name indicates, Geshiyaro, it's a local name, which means something which cleans inside and outside. So the drug is something which cleans the inside, and the WASH program which sustain the gain from the mass drug administration. So after we achieve 90+ coverage for drugs, for these 2 drugs, and albendazole and PZQ, we can break the transmission. As per the mathematical model, we can break the transmission, but we cannot sustain the transmission unless we are providing access to safe water, sanitation, and hygiene. So the program, the overall project is the integration of NTD program with WASH program. And the WASH program is customized to bring actually the desired change on the 2 diseases which is soil transmitted helminths and STH and STH, to break the transmission and to bring down the prevalence below 2%. So the first, from the WASH intervention, the first one is access to safe water. So when we say access to safe water, bringing water to the nearest of the community neighborhood, which means within 30-minute round trip. at this point, the project is actually targeting 85% of coverage in the 5 districts, which is the project main target area. In our case, we call it Arm 1. So we have, as a project, we have 3 arms. The first arm is 5 districts with intensified WASH and intensified MD. And the second arm is around 18 districts with regular WASH program and intensified MD, and the rest with a regular WASH program and the school-based MD. So from the water part, in these 5 districts, we are expected to achieve 85% water coverage within 30 minutes of access point. So every committee member needs to access water within 30 minutes round trip. And the strategy is increasing new water supply scheme, not only increasing new water supply scheme, but also rehabilitating the existing water supply schemes, which has been constructed before the project. So to address this ambitious goal, which is 85% coverage, which is nearly to universal coverage, deep wells have been drilled with motorized scheme and shallow wells. Shallow well, when we say shallow well, it is between 80 meter and 100 meter. When we say deep well, wells with more than 100 meter deep, and all these water schemes are motorized and supplied with solar powered or local available hydroelectric power. And the reticulation system or the extension system is with a distribution system. The water will be the water is distributed to the entire community in the nearby for the community to access water within 30 minute round trip. And not only deep wells or groundwater sources, but also spring development with gravity and pump system. As I said, also rehabilitation and expansion of existing water supply systems. And one of the problem of WASH program is sustainability. After we construct the water scheme, the water systems needs to be sustainable as much as possible. So governance system will be, actually the governance system has been in place for the programs for the projects, water projects, which we have been doing in the past 4 years. So rural utility system is our strategy. So those utilities are established to manage, operate, and maintain the water schemes which we constructed during the project time, which ensures sustainability. So in the 5, as I said, the 5 target woredas are Arm 1 woredas, 87 intervention cabalis. So in the past 4 years, we were able to drill 124 shallow wells, and out of 120 shallow wells, 24 shallow wells, 160 are productive. But the plan was 110. So according to the geographic situation, according to the demand of the communities, we managed to drill more wells than our plan. And out of this, 70 shallow wells are fitted with SQ Flex, which is a pump system fitted with solar power. So over 70 shallow wells are already fitted with solar system. This solar system is part of sustainable energy source, and it's already commissioned for the community, and communities are now benefiting from these water schemes. And 26 schemes are actually, by the time now, these 26 schemes are already finalized, and 30 shallow wells are already fitted with hand pump. So the difference is here. One thing this project brought to the WASH sector by itself is changing this hand pump based water system to solar powered water points, which is actually is the burden of mothers and children who are fetching water from those schemes. So, and also it's also reduced the waiting time of the community members while they are fetching, because the water point is for faucet, and when they were using the hand pump, one person at a time was able to fetch water. So in terms of reducing the waiting time, in terms of reducing labor, in terms of providing safe water, and in terms of sustainability, these solar-powered SQ Flex system are by far the most feasible one to fit on the shallow wells. So the project brought this innovative idea for the WASH sector as well. And even the WASH sector can learn from this one, not only for the NTD WASH integration, but the sector WASH by itself can learn from this one. And the other one is 20 deep well drilling. When, as I said, 20 deep well is from 100 and above meter deep. So these all 20 deep wells are already drilled, and only 12 civil or reticulation system which distribute water to the nearby communities are under construction, and we are confident that by the end of June 30 we will be able to deliver all the project deliverables in terms of supplying water for the communities from these deep wells. So the governance system, this multi-village schemes needs to be, the governance needs to be well established so that communities are accessing water in a sustainable manner for a long time. So the operation as well as the maintenance as well as the management, all things are coming under the rural wash utility. So this project brought this idea for the first time in the country. So the project is piloted in terms of piloting rural water utility, and we got actually a very promising result from it. And the government is also using this approach as rural water system management in the future. And now the communities can operate and manage the water systems due to these utilities. Just to show you some figures when we start the project as a baseline and where we are now as an achievement. These are the 5 districts in Wolaita. So just show you the difference. In Bolososori, the baseline was 54, and the water coverage is now 73. You know, one of the SDG goals is to achieve universal coverage. So this project is helping these districts to achieve universal coverage, at least by addressing their water needs, or until 85% coverage, and the rest can be covered by local communities or local government. In Bolososori, it was 49, now it's 59, but there are a lot of constructions undergoing at Bolosobonde, and at Damutgale 64, and now we are on 74, and there are also a couple of water projects under construction, so the coverage will be above 85 by the end of June 30. And the rest of the districts, for example, Damosori, it was 49.5, and the achievement is 75.8, and this is the 69% is the average achievement, which is nearly 70, and the rest of the 50% will be achieved in the coming months. So the next part is sanitation. You know, sanitation is a very aged concept in the WASH sector, but you know the achievement is not that much significant in many countries, including Ethiopia. So, you know, one of the problem was most of the sanitation program is vertically driven and charity based. So the communities are not actually holding the initiative and contributing for sustainability. So we come up with a Geshiyaro WASH business model, which is actually by creating WASH enterprise as a center of the model and creating demand and supply at the same time. So for sustainable market system in the community, there should be a proper demand, there should be a proper supply. At the same time, there should be a proper enabling environment in the community. So this project has been actually doing this initiative in the 5 districts for the past 4 years, including this year. So in terms of demand creation, the local government, which is the health bureau, microfinance institutions, and sales agents recruited by the project as part of the WASH business are the ones who are actually expected to drive the demand. And due to this all collaborative effort, we are expecting demand will be created in the last mile communities, which is each and every household. So the health bureau expecting demands through the health extension program. You know, the Ethiopian Health Extension Program is a very famous program, and microfinance are actually ensuring consumer financing, because the rural communities their income is in annual basis. They are farmers, and their income is agriculture based, so they don't have actually disposable income. So when we are actually promoting products, wash products, and not only wash product, but products which are actually helpful for the NTD, such as shoe. So shoes market needs to be actually established in the area. So for this all products, the community needs to access finance. So one of actually our intervention piece is the microfinance engagement. So microfinance are the one who supply the communities in terms of financing, not only for the communities, but also for the businesses as well. So it's a two-way financing mechanism from the microfinance. So the sales agents are also part of the WASH business model, which link up supply and the already demand created in the community. So they are the one who are doing actually door-to-door sales on credit basis by engaging with the microfinance. So the Health Bureau, the microfinance, and the sales agents are the one who are working in collaborative and intersectionally. And from the supply oriented, or from the supply side, World Vision or the Geshiyaro Project is the one who established those small businesses in the far rural areas of these 5 districts. And the government office, which is Job Opportunity Creation Agency, is also one of the governing body in terms of establishing these business centers. And technical, vocational, and training centers, which are actually government-led, but in terms of standardizing all the training, this institution is the one who is actually, which is helping the WASH business centers in terms of capacity building. And at the same time, microfinance will come at the supply side as well in terms of financing, as I said earlier, the WASH business enterprise. So these all actors coming together to make products affordable, WASH products and other products for their behavior change. These all actors' work is to make those products affordable and accessible at the same time. So this has been actually the project model which the project has been actually promoting, and we can say that through our effort in the past 4 years, we successfully deliver what's expected from the project. So the project target is 82%. So we're running to achieve this target by the end of June 30. So far, we established 40 WASH business centers or enterprises with 24 promotion centers in the 5 districts, which is on the R1. And the good thing is all the business operators who are actually member of these 40 WASH business centers certified by the local government to produce a slab, soap, and cooking stuff in other products. So this certification will help them to be in the business for a long period of time, because most people are not, if they are not certified, they cannot be in the business for a long period of time. But these business centers are certified by the local certification body. So this shows how our training was intensive and standardized, how the project support was in a very integrated manner with all stakeholders. And they were able to sell 23,000 slabs throughout the 5 districts within 3 years. And actually, this is part of strengthening the supply chain mechanism which the project is promoting in the rural market. So just to mention the product, as you can see the picture in the right side of the slide, there are different products: plastic slabs, plastic toilets, or those retrofit plastic pans, plus shoes, which is part of as part of preventing hookworm, and energy-saving cooking stuff as part of easing actually the burden of mothers who are actually in charge of doing all the household works. So different size of and shape of slab, soap with different quantity. As I said, cooking stuff and shoes is part of the product. So these products are intentionally selected to address the need of STH and SSH prevalence reduction. So by promoting these products, STH and SSH, and by proper use of these products, STH and SSH reduction will be realized. The other one is institutional sanitation. So previously, as I said, the business part is mainly focusing on community, and institutions needs to be part of actually this initiative. Unless otherwise we are including institutions, we cannot actually ensure prevalence reduction, because when we say institutions, schools and health facilities, just to give an example, in schools, students or children are spending most of their time in school. So if you are not providing the right products and the right sanitation facilities for these institutions, you cannot achieve the desired change in the entire community, because children and students are part of actually the community who contributed for prevalence increment or prevalence reduction. So one of our intervention is providing water for institutions as well, and the other one is providing sex-separated blocks of latrine, which the communities can use those latrines with dignity and privacy. So the communities, the children are not practicing open defecation in the school compound. So if they have their own sanitation facilities, they can practice proper sanitation. And beside that, as you can see the picture here, water is provided for each and every blocks of latrine and for the school as well. So students can practice proper hand washing after using toilets. So the other one, a very interesting point here is, as you can see in the picture there is actually a walkway which connects the classroom with the blocks of latrine. Here is actually the area. So this walkway will help the students to remind using latrines all the time. In the summer season, when school is closed, most schools in Ethiopia are actually practicing agricultural activity in the school. So when the students are getting back to school, when school opens, all the field is covered by agricultural crops, and that crop is not actually mostly collected within the first 3 months of the school starting time. So, due to this, students will not get access to the latrines, and they will get back to their original behavior of practicing open defecation in their community. So this walkway is it's all weather road, and when students are coming back from their summer break, they can still access the latrine with this walkway, and which is actually this project innovation or innovative idea which help the usage of latrines all the time. So this is all about what the water intervention and the sanitation intervention. So let me give the floor again for Milkias to go through the SBCC part, since he's the project owner for SBCC activities.
Okay, thank you, Endriyas. I'm back again. So now we'll be seeing the fourth or the last outcome of Geshiyaro Project, which is SBCC social behavioral change. So as you see in the screen, initially we have selected 7 behaviors, and these 7 behaviors are in direct relationship with reduction of the transmission rate for the 2 diseases. But these 7 behaviors were selected by doing a formative research at first. So the problems that the community were having or were facing was a problem with such 7 behaviors. So now we were thinking about doing the 7 behaviors, but working at a time on 7 behaviors is going to be very exhaustive, and it will be human resource intensive. So we have decided to reduce three behaviors, which are stated on the below: the safe water storage, the proper waste management, and proper latrine utilization. Not because they are less important, but they are as much important to the other behaviors. But these can be covered by the ODF part and also by the sanitation marketing part. It can be covered. So instead of duplicating efforts, it's better to focus on those behaviors that are not going to be addressed by other departments or by other sectors. So we have come up with proper hand washing. It's very significant behavior in reduction of STH, and also shoe wearing, avoiding freshwater contacts, and at last, drug compliance, because we want the community to be compliant for the drugs that are going to be given for them on a yearly basis, and for some drugs in biannual basis. So when we go to our strategy follows a surround sound effect approach. What we mean by surround sound effect approach is surrounding a community or surrounding a household with the different directions. So for this particular strategy, those directions are four. And the first one is the health system approach, because a mother or a parent cannot be outside of the health system in our structure or in our context. So health system is the main channel to communicate, especially mothers in the household, for the positive behaviors. So we have selected that stream. And the next one is schools, because every students are going to schools. So if we can target schools on schools for students, then message can be taken away for their parents, and also they can change their behaviors. So that was the assumption. And the third one is religious activities, or we call it faith leaders engagement, because predominantly the community that we are serving is under Christian religion, or they are following the Christian denomination. So targeting churches and also priests or preachers in order to teach their congregants or their followers to the key behaviors of WASH is going to be advantageous for the project. So we have selected that stream also. Last and finally, hoping to address the youngsters or the users, we have selected the mass communication approach. And in this part, we are implementing this mass communication with the selected brand ambassadors. There are 2 brand ambassadors selected for this project, so we are working with them. So by the time we start our project, most of the community members were on pre-contemplation level, which is they don't have clear understanding of the diseases and how they are going to break the transmission, or how they are going to prevent themselves from contracting these diseases. So that was the stage where the community were at that time, but by the time we embarked this project on those operational areas. So it was our responsibility to take through this community to the action level, at least, because they need to exercise and comply certain behaviors. So we have done this strategy, and now we have brought them to the action part, most of them, and we are working on that aspect. So this is the World Vision model, which we applied in different national offices of World Vision, especially in Ghana and other African countries. It's called Nurturing Care Group model. So the essence of this model is there is a one coordinator, which is based in head offices or in field offices. So that person is responsible to coach or nurture his subordinates. So those subordinates will be going and coaching and nurturing also the health, in our context, the health extension workers, which are the change agents for such activities and behaviors. So they will go and teach them, coach them, and nurture them, so that they will be an ambassador of these selected behaviors. And those health extension workers will be going to the health development armies, which is another structure found under the health extension workers. So they will be teaching them, and the last mile activity is going to be carried out by these health development armies or women development armies. So they are stratified with a network. One each day can have up to 30 households under her supervision. So she will be responsible to go to each houses under her catchment to teach those selected behaviors. So this is what we call nurturing care group approach. So it starts from the main person at the office, and then it will be going down to the field office, and then to the change agents. Lastly, it will reach out to the households. So these are the approach that we are following. The first wing of our strategy is health system. So what we did for this specific activity is we have designed a counseling card, which has a story, positive story of an individual or model households from their community. So these households are practicing good behaviors. As a result, they do have a better livelihood, and the health of their children and the household members it became better. So that's what the story is telling us about. And also there are key messages for each behaviors. For example, if you are talking about hand washing behavior, then we do have the steps of washing hands. And also we have these 5 critical points that a person should wash his hands. So all these things are included in this counseling card. And in addition to that, we have narrated it into an audio, because the level of our agents, change agents or health extension workers is not standard across the board. So we need to uniform the message dissemination part, so that we narrated these contents in the counseling card into a radio, so that these health extension workers, by the time they go to the households, they will be playing these narrated recordings, and they will lead the interaction or the communication within their households or within their groups. So it has been a tremendous activity, and it has brought very good achievements. The next, the counseling card will be used for showing pictures. There are pictures, illustrations. So they will be showing those picture illustration coupling with these recorded audios. This is all about the health system approach. So when we see data as our monitoring data, it's not an evaluation data, but we do assess our activities after every behavior. So one behavior is running for 2 months. So after 2 months, we'll see how many of households have been addressed with this particular activity, and how many of them are reaching to the level that we are expecting them to get. So this is the data. For example, in the first one, Damotsore, 90% of the households are practicing hand washings in their households. So the marketing division, as Endriyas presented earlier, they are providing soap. So they will have a soap from these wash business institutes or enterprises, and they will practice washing their hands with soaps as per our health education program. And also the knowledge that they used to have related to hand washing practice was predominantly they are associating it to ascariasis, and some amount of them are associating it with diarrhea. Still, they are correct, but our intention is so that they need to associate this hand washing practice with ascariasis, because that's the project was designed. So most of them, as we want them to associate, they are associating the hand washing behavior with ascariasis, which is an achievement for the project. And what HDAs or the change agents have confirmed to by going to each household is that each members of the community members have start practicing the hand washing practice as per the intention. So as you see the data, most of them in some that's 100% are starting to practice hand washing within their households. So this is also a remarkable achievement for this specific health system structure activity. The second one is school-based approach. So the new thing, or which is not common in most part of SBCC programs or in other countries, we have brought here a VR machine, which is virtual reality. So what we did is we just develop a script or a narration that states about good behavior or compliance of good behavior. For example, in terms of drug uptake or drug compliance, a person is taking a drug, and those drugs are going to kill those parasites within his body. So the picture is telling us about those stories in a form of animation or 3D dimension animations. So the children, when they see these videos, they know what's the purpose of the drug. So they know the drug is going to kill the parasites, and they will be communicated much better than other means of communications. So this is what we have done, and we have produced or developed 4 videos. So we'll be circulating these videos on a routine manner, starting from grade 5 up to 8, because there is age limitation regarding to the VR machine. Younger children are not recommended to see these VR machines because it has something to do with their eye development. So it's recommended to use anyone above age 10. So we are giving these VRs for those students, particularly starting from grade 5 up to grade 8 students. The second one is a school tournament. Our purpose is not to conduct a school tournament, but we want to create this mass mobilization or crowd, so that we will disseminate and convey key messages to the crowd. So runs, footballs and volleyballs are the most common thing that's being implemented in the operation areas, because the youngsters, the students love to play these games. So we have organized a tournament across schools, a sort of competition. So on those events, we will be disseminating key messages, and also we'll bring brand ambassadors, elected brand ambassadors, to teach and speak about these behaviors. The next one is comic book. This one is also the same as the VR, but this one is in a hard copy format, not in a soft copy. So it's more reading session. So it will be read in a school mini media, or they can use the content from the comic book, and they can do it in a poem, in a drama, in such forms. So they will use it for that purpose. And its main target is from grade 1 up to grade 4 students are the main target for this comic book activity. The last one here is establishment, which is this is an existing program, but we enhance or we capacitate, and also we do try to refresh those members of the school watch in a yearly basis. So we'll also equip them with the necessary equipments for, especially for menstrual hygiene management purpose. We're providing mattress so that the students with menstruation is going to rest over there. And also we provide cleaning materials which they use. It can be pads, can be soaps. So mainly we are providing equipments to support the established WASH club. So also when we do outcome monitoring for this specific activity, there are associations that we want to see, and students start to associate shoe wearing behavior with the designed behavior. For example, for this part, most of our students are associating shoe wearing behavior with a hookworm, which is our intention. And around 5% of them are associating this shoe wearing practice with schistosomiasis, and 12% are associating it with trauma, and the others with tetanus. So majority of the students are associating the shoe wearing behavior with the hookworm. That was the intention. So we can say that the project is accomplishing the target almost. And the last one is avoiding freshwater contact. So as you can see, 68% of the students or the respondents were associating freshwater contact with schistosomiasis. That's also a remarkable achievement for this activity. And the rest are associating it with amoeba, with other waterborne diseases, which is true. But our intention was to make them associate with schistosomiasis. So that has been achieved. And the next one is also another outcome monitoring assessment in regards to VR activities particularly. So students have tried to practice the desired behavior after watching VRs. So as you can see, around 35% of the students are starting to wash their hands at the 5 critical times, which is a good record. And the rest, they have started to wear shoes at all times so that they can protect themselves from hookworms. And the rest are avoiding freshwater contacts in order not to contract schistosomiasis. So this is also a wonderful achievement that the project has recorded after displaying VR on the SBCC part. And the third wing is going to be faith leader engagements. What we did here also is we developed a new manual for religious leaders. It targets Christian religious leaders because predominantly Orthodox and Protestant is being, or evangelical are the most followed religious in the areas. So we have focused on Holy Bible, but also we have a plan to expand it to the Holy Quran and also other available holy books. So we have trained this number 419 religious leaders. So they are going to preach on their sermons on Sundays or on Saturdays. They are going to preach for their congregants about WASH behaviors, about the advantage of complying for positive behaviors, what's going to result as a result, what they are going to achieve for following or for complying for such behaviors. So there is a high tendency for any congregants or any community members to listen to the religious leaders in their community. So they are complying, following the preach that's coming from their faith leaders. So this was also a remarkable achievement, and more than 175,000 community members were reached through this activity in a 2 years period of time only, because we started this activity lately, but more than 175 individuals were reached through this communication channel. And the last one is mass communication. It's widely used in many SBCC programs because it's easy. But in here, we have onboarded 2 brand ambassadors. The one you see on the right side of your screen is the very prominent artist located in Ethiopia, and also he's grew up from that particular area. He can associate the language, he knows the culture, so he has developed a good music that speaks about hand washing and maintaining environmental and personal hygiene. So most of the time users are, he has a number of followers on Instagrams, in different social medias, including YouTube's. So all those youngsters who are following him get to see these messages, and some of them are, complying for the call that he has passed on his musical videos. And the second video, the second picture you see on the right bottom is a roadshow. We are collaborating with local art groups so that they improvise the hand washing behaviors with artistic features for the audiences that are gathered in the main roads. So they are showing this for anyone who's coming to the main roads to witness these artistic features. So we are carrying out this once in a month, while the town crier is going to be carried out twice in a month, sorry for that one, twice in a month. For roadshow is going to be once in a month. And the last one is, we don't totally abandon IC materials, we still produce them, but we don't rely on IC materials, because we have seen in many documents, and also it's going to be proven that IC materials are not working as intended. So we rely on other SBCC activities, but also we include IC material just to remind some of the communities, because when they see these posters and messages mounting on the streets, on the walkways, they do have a tendency to recall and memorize the message that we have communicated them so far. So then this is also the mechanism that we are following to monitor that this SBCC activity is being carried out as per the plan. So we do have a routine meeting with the Woreda health officers, with the local authorities, and also the local Ministry of Health. Also, we do have a meeting with the political leaders somehow, because sometimes things are not going to be pushed by technical leaders only. Political leaders' engagement and advocacy is also needed. So we do have a routine briefing meetings with political leaders. We do have a tracking dashboard that we have prepared. It's a checklist, it's a hard copy, it's a manual. So every time we'll see that checklist, whether it has been filled or not. So how do the attendance rates looking for this week and the coming week also? So we do track all those signatures and attendance sheets regularly. And the last is the outcome assessment, which we have, which I have showed you earlier. So every other 2 months we'll be running this outcome assessment so that we know on what stage we are and what improvements needs to take place on the specific activities. Lastly, combining all these activities in integrated manner, what achievement did the project accomplished? So we are going to measure this in prevalence. So we need to see the trend of the prevalence for the past years. The below ones are the whole project lifetime, because the project started on 2018. But in the middle, COVID was there, and some political insecurity was also there. So there was intermittent implementation. It was somehow interrupted for these reasons. So we would like to see the above one as of FY 2020. So as we see the trend of ascariasis, and for all diseases, I can say, it's reducing very, very dramatically. So it's a very wonderful record. So this is what it looks like, the overall. I think this is the last slide. Yes, so thank you for your attention. Any questions that you have, we'll have them to address. Maria, over to you.
I'm sure everyone will join me in saying we absolutely loved this presentation. It was incredible work, so impressive across so many things. You've really shown partnership in action all the way from the Ministry of Health level, across funding partners, CIF, and research partners, the London Centre for Neglected Tropical Disease Research, to local partners in Ethiopia, even the biometric kind of fingerprint technology, and then, of course, those amazing communication and community engagement initiatives. So it was really awe-inspiring. My goodness, you've been busy at the Geshiyaro Project, and not only is this a fantastic blueprint in terms of exploring breaking the transmission in schisto and STH, but also really inspirational for anyone working in public health. So thank you very much. And I suppose, and many of our attendees, I don't know if you've had a chance to hop over to the chat. Dr. Obiageli Nebe, hello and welcome. Congratulations for the great presentation. Ogechuku Aribodor also saying great presentation, very insightful indeed, and really lovely to see all these many attendees here. So I suppose my first question, looking at all the many partners that you've involved in this was just to ask a bit more, what has been your experience of navigating this, and any advice you might have for colleagues either working in schisto and STH or even other tropical diseases, about what have been some of your challenges, but also some of your learnings along the way of marrying so many different partners and doing it successfully, may I say.
Okay, thanks so much. It's a very wonderful question. So, you know, NTD program is a very integrated approach of different sectors. You know, WASH is one of actually the sector which is on the table for a moment. So, bringing different sectors together is one of the challenge. Different, when we say different sectors, different organizations, different working background, different working interests coming together for one goal. You know, WASH, it has its own goal. When I say it has its own goal, it might be decreasing diarrhea prevalence, or it might be ensuring coverage, but bringing down or customizing the WASH program intervention for NTD is one of the lessons which everyone needs to learn. So when we plan to bring WASH intervention for NTDs, we need to customize it. We need to bring it down to the level of what the NTD program is demanding for. Our SBCC program is designed to address the exact need of STH and SSH. In most WASH program, hand washing is the most prevalent behavior which the WASH program is promoting. But in our case, we intentionally include shoe wearing, avoiding freshwater contact, and drug compliance, because these behaviors are mandatory and important for the achievement of prevalence reduction, or reducing the prevalence with the expected level. So the other one is water. Providing water is one thing; it's a human right, but providing water for the purpose of STH and SSH is another thing. So the project focus was not only quality water, but also enough quantity of water. If communities are not provided with enough quantity of water, they cannot practice the desired behaviors, because if water is scarce, they can actually prioritize for drinking and for other purpose. Even they still can go to fetch water from rivers, which expose them for freshwater contacts and other other factors. Even in terms of sanitation, the sanitation marketing, the common term, which is sanitation marketing, which is mainly developed for providing access for communities in terms of providing access for slum or the latrine facilities. But in our business model, we intentionally include soap, we intentionally include shoes, because these are part of the effort to reduce the prevalence of these two diseases. So when we bring other sectors to the picture, to the table, we need to customize it towards the desired change that we want in the NTD. Milkias, do you have anything to add?
Yeah, sure. On top of what Endriyas has said, I think most NTD programs or WASH programs in our countries specifically, I don't have much experience about what's being done in the other countries, but here in Ethiopia, we normally oversee the religious leaders. We are not collaborating with religious leaders. So it's very critical and vital for any program implementers to collaborate with religious leaders, because we have seen them playing a massive and great role on mobilizing the community and creating these behaviors.
Yeah.
So it's very wonderful to put them in the equation of our programs. 1, 2, in a place, for example, where poverty massively prevails, I think it's very good to have IGA activities, for income generating activities, because we need to support the community. Because whenever we are teaching them about shoe wearing, in other words, we are saying them to buy shoes. So for this community, shoe is not a priority, definitely, because having 3 meals a day probably can be their priority. So also creating them an income generating activity so that it can support, or it can help us to buy these shoes or the latrines or the soaps, all those products. It's going to be useful. So again, most of the time it falls off our radar. So we need to also include IGA activities. And the rest challenge-wise, I think most of our challenges are internal. We can solve them. It's internal challenges. Normally, if you are implementing a project, challenges are inevitable, but overcoming them, it's one part of our duty, I think. So luckily, so far we've been to overcome all these challenges. And the other one is the integration with sector offices or other localities. It's also wonderful and a very great thing for any project success. So in this project, I think we did collaborate with the localities, with the local health departments, with the local agriculture department, and also other sector offices. We do have a great collaboration. That's also a great factor for this accomplishment so far.
Yeah, I think it's worth to add one additional point here. Actually, I was expecting Milkias to point out that it's about the biometrics. One of the biggest challenge we were facing when we are actually implementing biometrics. by its nature, it's very new for the entire community.
Sure.
And actually, the community perceived it as if it's Illuminati or the 666 thing, because it's a new technology, and we brought that new technology to the rural far communities, and some actually bad behaving people in the community aggravate the issue by linking it with the religious belief of the community, because majority of the community are Christian, so they link it up with Illuminati, the satanic movement, and within a week period of time, our all work was actually sad. Everyone cannot actually accept what we are doing, even the water intervention, even the sanitation intervention, even the SBCC intervention. So when our vehicles were in the village, they were throwing stones in our vehicle because these people are coming to change our religion. These people are coming to promote this satanic movement. So this was actually the very big challenging problem at the beginning of the project. So as Milkias said, after we faced this challenge, we decided to find actually a real solution which solve this problem once and for all. So we decided to engage religious leaders. So we gathered all religious leaders from the entire 5 districts, and we go through a series of discussion with them. So these religious leaders are the one who saves the project. I can't say who saved the project. So they go back to their communities and teach their communities and influence their communities to be part of the project. And the communities are well influenced to accept the biometrics. And even after this achievement, we decided to include the religious leader intervention in our SBCC strategy, and we made them actually part of our intervention, which Milkias has been actually presenting in the SBCC section.
That's incredible.
Thank you.
You've clearly thought about this so carefully, and that's been really interesting. And the biometric issues obviously remain a problem across anywhere where they're rolled out, so that's to be expected. But that was really fascinating. It ties in a little bit. You were mentioning the religious leaders. We had here a question from Ogechukwu Aribodor, who was asking, did you encounter any water deity worshippers? And if so, what type of recommendation did you make? So maybe a broader question would be, how easy was it to work with communities' existing practices or beliefs? And how did you go around about that particularly?
Hello, Maria.
Yeah.
Did you say Water Day? What was it? Is it Water Day? I didn't catch it.
It said, the question said water. I assume it says water deity worshippers. So any beliefs or religious beliefs about gods related to water deity worshippers. I hope, Dr. Aribodor, that I've understood your question correctly. If not, just pop some more detail in the chat.
Okay.
Or perhaps
if someone dropped the question in the chat box, that would be good. Yeah.
All right, we'll come back to that one. No worries. So coming back,
sure.
Coming back a little bit to what you were saying about the challenges, and thank you, because that was such a useful answer. There was a question here from Elisha and Abulele, and you've answered half of it, part of it, and the other question, the other half of Elisha's question was about any plans on how to sustain the project after the funding elapses. And I suppose thinking about the future and the sustainability, so whether it be in terms of the funding, but also this tied in quite nicely with a question from Martin Coleman. Hello, Martin, who points out that the main challenge is sustained behavior change. And how do you plan to monitor this? Again, turning to the future.
Sure. Yeah, that's a wonderful question. I mean, sustainability is the issue of any project that's been raised in number of occasions. So yes, we have thought about it. What we did is first, I mean, we believe as World Vision or as a Geshiyaro Project, sustainability starts from design period. So if you are designing a very hard to follow, hard to sustain thing, then probably it's going to fail. It's going to crumble. But what we did here is like our design is very simple. The manuals that we have used, it's very simple. It's not that much costly. So we are, for example, now there are graduated Kabbalists or districts, and we normally follow them, whether they are, cascading this knowledge to their households, to their community members or not. But fortunately, they are, trying to take this message to the community by themselves. And the reason why this is happening is because the ownership of the governments or the stakeholders, the localities in there was massive and it was super. So the Warada or district health leaders and also the Kabali, which I said political leaders earlier, those political leaders have consumed and owned this thing to carry on it by themselves without our assistance. What we did is we just showed them the way, how it's going to be carried out. Now they have seen the emotional benefit, the economical benefit, the functional benefits. So, they are being, adapted to complying such behaviors. This is one part. The second part, the business by itself, the point that the WASH business is in the equation is for sustaining such behaviors, because the business are running by themselves. They are, now there are a number of business enterprises that don't need out of 14. There are a couple of WASH business enterprises that are not needing our support, so they are sustaining their business by themselves. So those enterprises are promoting the products that they are offering to the community, and while they are offering these products, they are also selling a behavior to the community members. They are also promoting the behavior. So this is also one strategy to sustain these behaviors. And in other programs, in the water parts, in the infrastructure parts, we do have also other approaches, which Endriyas is going to take us through maybe.
Yeah, just to give you a very general, thank you, Milkias, a very general, actually, sustainability strategy. One of the main strategy is engaging local government from the inception of the project up to the end. So if they are part of the project, most projects are failing because everything is sorted in the office of the charity organization and ended in the charity office. So when you phasing out from the project, that's the bigger challenge for the local community to take it to the next level. So for our project, local government engagement is actually, it has been very high, and even government is part of the implementation. World Vision is international non-governmental organization, but Federal Ministry of Health is part of the implementer or part of the implementation in terms of administering the drug for the entire community. So government is as a regulatory body, at the same time as an implementer, part of actually the initiative. This is one of actually the sustainability strategy. The second most important point is all the interventions are designed to support each other. The water intervention is supporting the behavior, because if water is available, the behaviors can be sustained throughout actually for extended period of time. But if you are teaching them, if you are giving the lesson of hand washing but without water, that's actually a big challenge for the communities to take back to their original actually unwanted behavior. So these are actually interlinked, plus those locally available enterprises are providing actually those common products for the communities to practice the desired behavior for these two diseases. For example, for hand washing, soap is mandatory. These local businesses are supplying soap for the community for long period of time, or for the coming many years after the project is phasing out. The community needs to wear shoes, and these local manufacturers are providing soap shoes for the communities. Latrine is mandatory for each and every household to use in a daily basis, and these local enterprises are the one providing this service for the community. So different interventions are strategically designed to address the sustainability challenge as well. Thank you.
Thank you very much. That was a great answer. We had a couple more questions. One of them, I'm afraid, disappeared when I refreshed my page. But if I remember correctly, this was a question from Professor Poppy Lamberton at University of Glasgow, who was just focusing a little bit on the figure that you gave. It was over 80% of coverage in terms of the water supply. And I believe Poppy was asking whether this related to just water supply or, oh, here we go, or if it was also a target for safe water that was also suitable for washing and drinking and so forth. Coincidentally, the question just reappeared in the Q&A. So I'll read it out. Poppy's writing, thanks for such a great talk and amazing project. For your targets, for example, 85% coverage for water supply, is this just a target for infrastructure, or infrastructure that provides water which is safe for drinking and washing? And also, what about the uptake of these water sources and the proportion of time people actually use them? Did you have targets for those two?
It's a very important question, actually. You know, as per the SDG target, those are actually the target of SDG. When we say universal coverage, the infrastructure needs to be there. At the same time, the utilization needs to be there, because the overall actually target of giving access of water for communities is not actually in placing the infrastructure, but the ultimate purpose is for the communities to access the water throughout the day. So our target is both actually providing the infrastructure as well as the utilization. But when we say this one, quality and quantity is mandatory. As I said in my presentation, we need to maintain the quality of the water schemes, because at any point the water scheme can be contaminated. So water quality test kit provided for each district, including training. So there is a regular water quality checkup by the local government. This one is to actually improve the quality. And from the quantity point of view, every household needs to get, actually the water system is designed based on the demand of the communities, which is 25 liters per day per capita, which means a 5-member household targeted for 25 times 525 liters of water per day for that specific household. And the design of that water scheme is to provide this amount of quantity water for the community. So as part of our behavioral change intervention, we are still actually promoting the use of water for all purposes. You know, there is a common perception in the community of using those safe waters for drinking only, and for the rest of domestic purpose, there is actually inclination to use other sources of water. So our SBCC, or social behavioral change communication effort, is to teach and actually to give those important lessons for the community to use this water for all purposes, because the water is enough for all purposes. Our design is for all domestic purpose. When we say all domestic purpose, including drinking, washing, and other domestic, including actually bathing, cattle trough for their cattle as well. So the water is enough for all their domestic purposes, and our project target is also to break the barrier of behavioral barrier of actually using water for all purposes. Yeah.
Fantastic, thank you. That was a very clear and useful answer. Just returning back to Ogechukwu Aribodo's question, which was, yes, about deities or gods that were related to the water, whether it was the community worshipping the spirits of water or any aquatic animals, whether that was something that you had come across, or just maybe opening up that question a bit more generally. what have you found was useful, or what was a useful way to incorporate any community habits or beliefs into some of your targets?
Yeah, I think such incidents haven't occurred in our journey of implementation, project implementation. Only the one thing that was occurring on the formative research that we did before beginning or before developing our strategy was there is no harm for a mother and the water. So any water is useful, or any mother is not harmful, so does water is not harmful. That was the assumption. So it was, less easy for us to tackle this behavioral barrier, and which managed it. But the other superstitious beliefs that we have come across in this implementation period. So because most of them are, in the same denominations, and those denominations are, more or less preaching about Christianity and all those things. So on the Holy Bible and the rest thing, there are not such beliefs in order to dilute the minds of our target individuals. So this is not the context in our operation area.
That's good to know. And I suppose we are coming up towards the end of the time for this webinar. And so by way of conclusion, I probably had a question building on that, and which was to ask you, obviously this has been a hugely successful project in the areas that you were working in. And the goal of the Geshiyaro Project, one of the many goals, should I say, is to scale up interventions to break transmission, and working with communities. On the one hand, you do need to have very local and very targeted approaches, but when you're scaling up, you're going to be looking for solutions that can be applied very broadly. And so how will you, going forward, balance these two requirements, and what might be some advice to anyone else, to other projects or those working in other diseases who are looking to scale up, whilst at the same time retain some of that very successful local impact?
Yeah, it's a good question, and also somehow it's I would say it's difficult. But for other projects, probably my recommendation is, again, it's what I have said earlier. As a public health, SBCC activities are normally cross-cutting programs. So, but we are not implementing the SBCC up to the standards, because if you are implementing the SBCC part to the best part or to the utmost part, then our efforts on other activities is going to be put on as I would say for greater part. So designing context or community-specific approaches is going to be very helpful, because this, for example, our SBCC approach can be implemented in other projects, in other NTD diseases, and also in other, for example, nutrition program, in maternal health program. You can apply it because it's very easy, and there are also many supporting scriptures and stories from the Holy Bible that will be, used for other programs as well. So, putting a thought on it, or, doing a very in-depth formative assessment or researches is going to be helpful for this one. And the other part is, it's not that much resource-intensive project that we are implementing here. For example, in Ethiopia context, we can take it to the other region, to the northern part of Ethiopia or to the western part of Ethiopia, and we can apply it by just changing a few contents. For example, in SBCC, if you are, going to the Muslims community, then we need to bring Holy Quran into the picture, not the Holy Bible. And also for the water part, it's going to be the same across all the sites of the country. The governance part also is going to be the same. The MBD part, of course, drugs are expensive, but as long as we do have the supply chain, I think we can replicate, or we can, do it in other. We can scale it up in the country or beyond, in continental wise, probably. So I think it's a very good design. But for those communities which are under poverty level or which are on a severe poverty level, we just need to bring some kind of income generating activities to support the community to catch up with our demands. That's what I would say. Maybe Endriyas can add.
I think for the purpose of our time, it's enough to conclude the question with Milkias' answer.
Great. Well, there certainly isn't enough time to cover all the incredible and varied and numerous touch points that are included and involved in the Geshiyaro project. It's been an amazing 90 minutes, and it's been a real honor, but also a pleasure to hear so much from all the different angles and partners that this project is bringing together. So again, a really, really massive thank you from the International Society for Neglected Tropical Diseases, from the Global Schistosomiasis Alliance, and also from all our many attendees who I'm sure will join me in thanking you very, very warmly for your time today. So it was a real pleasure having this meeting with you, and we can't wait to hear of more updates, and we'll be keeping an eye on the next steps for the Geshiyaro project. So a huge thank you very much. And thank you to our lovely audience, as always, for joining us and for posting such insightful and useful questions. And Roseli Tuan has just added congratulations for such a wonderful presentation. Professor Poppy Lamberton was saying thank you for your great answers. So from all of us, a big thank you, and we hope to catch up very soon with you.
We thank you also from World Vision Ethiopia. This is actually a great opportunity for us to showcase our work for the international community. And I would like to say thank you, Milkias and the Global Schistosomiasis Alliance, to brought our project to the picture. And we're happy for that.
Also, Mercs are the one who linked us with this platform.
Yeah, so we're very happy, and we are very grateful and thankful for your opportunity. Thanks so much.
And thank you, Mariana, for wonderfully moderating this session also. Yeah. And also thanks the audience.
Yeah, thank you to everyone here today. And we'll see you very soon next week with the focus on snakebite.
Great.
Okay. Take care, everyone.
Okay, wonderful evening.
All the best.
Bye.
Have a good evening. Bye-bye.
All the best. Bye.